Now, we see patients doing so well from their cancer, but then they're doing so bad
No other option has worked so far.
that we have options as dermatologists to improve their quality of life.
with a very huge impact in terms of quality of life. Keep pushing.
Well, hello everyone, and welcome to this new EADV podcast dedicated to the dermatologic adverse events associated to immune checkpoint inhibitors. We're gonna go through their management, their real clinical practice, relevance, and points that we have to remember. My name is Azael Freites Martinez, and I am a board certified dermatologist from Spain, and I'm also the co-chair of the EADV Task Force of Dermatology for Cancer Patients. And today I will be moderating this discussion. I'm happy to also have here joined by two internationally recognized experts in supportive oncodermatology. From one side, Dr. Zoe Apalla from Greece, Thessaloniki. Yes, so you are there, and she's also the co-chair of the same task force we were mentioning before. And our chairman, Dr. Vincent Sibaud from France, Toulouse. He is also, as I mentioned, the chair of our EADV Task Force of Dermatology for Cancer Patients. Over the next 20 minutes, we'll be discussing why the skin is actually so frequently affected by immune checkpoint inhibitors, and also how to recognize these common side effects and the role of newer therapies we have to treat these conditions. I would like to begin first to highlight something in general about the checkpoint inhibitors, that these therapies works in a certain way as antibodies that remove the inhibitory brakes from T cells in a certain way, allow the immune system to actually attack and kill the cancer cells. But as you know, skin is the largest organ, and also there is a lot of immune reactions happening regularly in the daily basis in the healthy skin. So that's why the skin is highly susceptible for dermatologic adverse events with these therapies. So I would like to start with the first question to Dr. Apala. Which cutaneous or dermatologic adverse events you see first or more commonly related to immune checkpoint inhibitors?
Well, the list of checkpoint inhibitors related skin toxicities is quite long. However, those that we mostly encounter in our daily practice include pruritus. Pruritus can be seen as an isolated symptom, but can also accompany another rash. We can also see lichenoid, eczematous, and psoriasiform rashes. We can also see pigment changes like vitiligo, which is more common in the scenario of melanoma patients. And we quite often expect to observe nail and hair changes. Individuals with a family or personal history of a pre-existing autoimmune autoinflammatory dermatosis are in a higher risk for the development of an immune-related cutaneous adverse event, and it is expected that they usually experience exacerbations of their diseases when they start on checkpoint inhibitors.
Good. Yeah, and that brings me to, to you just mentioned one basic conditions that we dermatologists sees in the general practice, which is psoriasis. And we know that more than 5% of the total general population may suffer from psoriasis in general. So now we go to the next question to Dr. Sibaud. Maybe he can help us with this. When and why cancer patients treated with immune checkpoint inhibitors should be seen by a dermatologist? And what would you suggest to the general population and to general dermatologists as well?
Well, Azael, I think it's a very good question, and it's very important also to educate medical oncologists on this question, because the goal is obviously not to refer all patients with dermatological toxicity related to immune checkpoint inhibitor to dermatologists. It's just impossible in real life. So It is also important to bear in mind that in the majority of cases, this dermatological toxicity remain mild to moderate in intensity and can be more or less controlled in about 80 or 90% of cases with an appropriate skin-directed therapy. So um, we can also say that, globally speaking, even without specific experience in oncology, dermatologists will always offer more appropriate dermatological management in comparison with oncologists, due first to the knowledge of of inflammatory dermatosis in general and about the skin homeostasis. So to summarize, I would say that the patient who present resistant to first-line skin-directed therapy, or patient presenting atypical or severe skin reaction due to immune checkpoint inhibitor, or patient requiring oncological treatment interruption should be referred to a dermatologist. So both for an accurate diagnosis, for sure, since, as previously underlined by Zoe, immune checkpoint inhibitors can be associated with a wide range of different skin tox, and also to optimize management of our patients.
Right. And it's interesting because generally speaking, dermatologists see that, well, maybe they believe that it is not that frequent, but it is. The thing is that generally these side effects are well managed. The grade one, which are just that do not really affect for the daily life and they're not that spread, are managed by oncologists. They have guidelines available, and it's actually part of them to control them. So that's why we see probably more complex side effects or advanced or severe reaction. All right. So at this point, I would say I would like to just create a imaginary case. Just let's say a man in his 60s with melanoma treated with pembrolizumab, and after 6 months of treatment, the patient developed intense pruritus and eczematous reactions involving maybe 20% of the body. I don't want to make it so complex, but it's an easy question, Dr. Apalla. How would you manage generally these immune checkpoint inhibitors related pruritus and eczematous reactions in your practice? And what are the guidelines that we have available for us?
Of course, there are guidelines, and in fact, as Vincent said, the treatment should be individualized based on disease severity, the toxicity severity, and also the needs of the patients, and also the how the side effects influence their daily life. For mild grade one cases, we should try to manage with topical measures. Definitely, we should prescribe a rich emollient because we know that pruritus and eczematous rashes are accompanied by severe cirrhosis. We should try to manage the skin rash with topical steroids and topical calcineurin inhibitors as second line. And we can also use antihistamines. However, I should state that pruritus caused by immune checkpoint inhibitors is generally considered a non-histaminergic form of itch. This means that H1 antihistamines are often ineffective in this context. We know that immune checkpoint inhibitors related pruritus is mostly emerging from IL-2 signaling and T cell infiltrates rather than the histamine release. So short low dose systemic steroids can be used in refractory grade 2 and 3 rashes. Gabapentin, aprepitant, and UVB narrowband can be also considered, but we know that there are some limitations in terms of safety and practical issues that we can face with these options. Biologics, of course, are very, very important in the context of immune-related cutaneous adverse events. Especially for eczematous reactions, we know that since these kind of rashes closely resemble atopic dermatitis with the predominant Th2 driven inflammation. We know that dupilumab and also tralokinumab are used with a high success. They are very effective in the context of this kind of eczematous rashes, and they are used as steroid sparing agents. There are many cumulative data in the literature. We also shared our experience in our journal in the EADV recently, very recently, a multi-European, let's say, study published by our task force, Dermatology for Cancer Patients. Of course, also omalizumab is another a good alternative to steroids. However, to my experience, and I believe that you agree with me, dupilumab is doing better in terms of managing pruritic disorders associated to checkpoint inhibitors.
I
Yeah.
completely agree with Zoe.
Yeah, and it's interesting that we see patients doing so well from their cancer and their cancer treatment, but then they're doing so bad. They're doing, they're going so bad with their pruritus at the point that if you have a patient sent by dermatology to the dermatologist by the oncologist, be aware that probably you will need to go to these other therapies that you mentioned, the dupilumab, for example, because they have used already the basic ones. But also, I would like to highlight the basics, as also so I mentioned that emollients, for example, is the standard treatment that usually the nurses know this already and they use it in their patients, but sometimes they don't, especially in wintertime, cold, the hot water, dry their skin, produces cirrhosis, and this should be managed even before the pruritus is present in a level that is difficult in their life. And by the way, I would like to remember or to let you know that we have available patients leaflets in the EADV website regarding the prevention of side effects of cancer treatment, of cancer therapies in general. And also we talk more about pruritus management in these leaflets for your patients. Now we talk about pruritus, which is basically the number one reaction seen with immune checkpoint inhibitors. But I would like to ask Dr. Sibaud, what do you think about psoriasis? Psoriasis-like reactions and lichenoid reaction. How would you manage these? How do you handle these reactions in these patients receiving immune checkpoint inhibitors?
Well, Azael, once again, it is important to repeat that a majority of skin reaction induced by immune checkpoint inhibitor will be managed only with topical steroids and emollients. So this is a good news. But I think it is also important to make an accurate diagnosis between the different dermatological manifestations that can be observed with such monoclonal antibodies, particularly, once again, for patients with refractory lesions to topical steroids or with severe reaction. And in any case, this is my counseling, in any case, before introducing any systemic treatment, especially systemic corticosteroid therapy for the most refractory cases. So, a specific dermatological management should be proposed for such patients developing severe or recalcitrant psoriasis or lichen reaction, symptom by symptom. So, uh, can be provided by the dermatologist and, of course,
Yeah.
depending on the patient presentation. So the good news for the clinician and the physician, especially for oncologists, that the physician can now rely on up-to-date dermatological algorithm and with algorithm symptom by symptoms. And I will quote the latest recommendation, which has been published 2 or 3 months ago in the Journal of the European Academy and led by our friend David Fattori. However, to synthesize, the management of such patients, refractory patients, and requiring systemic therapy should, in any case, involve multidisciplinary collaboration, including, of course, input from dermatologists, input from oncologists, and sometimes, when appropriate, input from other specialists.
Yeah, and this actually is actually very good point Vincent, and you also raised a comment that we need to make these decisions sure with our patients and the oncologist as well. And generally speaking, cancer patients are very aware of this, and they probably will never receive something from you as a dermatologist before asking their oncologist because they usually have an excellent relationship. And I would like to highlight something that had been reported recently, and we believe this from years ago, that we need to identify very well that rash and differentiate it. So when we are not sure, don't base only on clinical features, and also use biopsy when needed, when required, to actually specify if this is a psoriasiform rash or maybe a lichenoid reaction looking similar to a psoriasis rash. So biopsies there, use it, and you as a dermatologist, you will be referred patients for this only just to classify very well, because we are the skin experts for sure, and we need to put the right name on this. Dr. Sibaud, you mentioned the biologics therapies, and I believe that they are now the future for the management of these side effects. And IL-23 inhibitors, for example, how would you recommend these therapies, or IL-23 or IL-17 inhibitors? How would you manage them? How is your experience? How have been your experience with them?
To be honest, Azael, I think it's not the future; it's the present because it's an emerging topic, not only for skin tox, also for other tox involving other organs. So it's very important to be aware on that. Because I strongly believe that biologics now play an important role in the management of severe or refractory patients, and if possible, at an early stage to achieve a steroid sparing effect in patients who are often exposed to very high dose of corticosteroids. So now we can say that collectively, the available evidence indicates no significant increased risk of malignancy or cancer recurrence in patients exposed to IL-17 or IL-23 inhibitors, including in patients with an history of cancer. So this potentially lower risk profile of IL-23 or IL-17 or IL-4 inhibitors is supported both by mechanistic consideration and clinical evidence from clinical trials and also real-world studies. I would like to underline that very recently a group of international experts in this field, which were led by Professor Papp from Canada, has published recommendation and position paper in the Journal of the European Academy on the use of biologics for the management of psoriasis, severe psoriasis induced by immune checkpoint inhibitors. And we can underline that the use of IL-23 agents were unlikely to impair immune checkpoint inhibitor efficacy. I will not detail the use of JAK inhibitors in the oncological setting because it's more conflicting. But finally, my recommendation which we can provide together are to use in first line after topical treatment for sure, IL 17, IL 3, 23, IL 4, IL 13 inhibitors in comparison with TNF or JAK inhibitor, which should be used with caution in oncological setting and only when no other therapeutic alternative are available. So finally, my recommendation is to use quite early biological agents when it is required.
So you would like to add something?
Yes.
Yeah.
May I make a comment just to expand a little bit the discussion? As Vincent mentioned, these adverse events are usually very complex, and sometimes we may observe the concomitant presence of more than one adverse event, not only from the skin as an organ, but also from other organs. For example, we see arthritis very often. We also see inflammatory bowel diseases. And I think that these targeted treatments, since we know that quite many of them have many are licensed for other indications that can be used together and cover all this spectrum of concomitant toxicities together, is a strong weapon on our hand. It is very important to be aware of all these drugs that we have in our armamentarium, and all the indications, of course, keeping in mind that we have to preserve the immunotherapeutic effect of checkpoint inhibitors. This is my comment in the discussion.
Yeah, no, very good. So thank you. And I would say, just to wrap it up a little bit with this, it would be smart to say that we should be very specific, or as specific as possible, when we're targeting these therapies, and maybe start with IL-23, that in the immune system cascade has less interaction with the immune system, for example, and then leave for a second instance, especially in patients with immune checkpoint inhibitors treatment, IL-17, because also the risk of colitis, for example, see if there is.
Exactly. You're right.
And the last,
Absolutely agree.
like, if you don't have any other option, or the previous option didn't work out, maybe the JAK inhibitor, because it's still not well recognized as an option, as a effective, not only effective, but safe options in cancer patients. So we're still a little bit reluctant to use them widely. So
Exactly. I think that the data for JAK inhibitors are still immature. We need more data. However, still we know that there are specific individualized scenarios in which no other options work. And if checkpoint inhibitors is a life-saving option for the patient, then maybe we should proceed also with a JAK inhibitor. But at the moment, systemic JAK inhibitors should be used with caution.
It is also interesting to note that very recently it has been suggested a synergistic effect between JAK inhibitors and immune checkpoint inhibitors in the management of different advanced cancer, especially lymphoma or lung cancer. But we still need more information before recommending using JAK inhibitor in this oncological
or
context.
let's say systemic JAKs in general, and maybe
Yes.
keep the topical as an option, probably.
Yeah.
Yes.
All right, Dr. Apalla, now that we're talking about all of these novel therapies, one that is have a lot of some years or more time in the market, like the how do you use it for the adverse events in general? Do you just keep it for pruritus, or you use it for more conditions?
This is a very nice question, and just to separate, let's say, dupilumab and tralokinumab from the other targeted biologics, I would like to comment that in terms of safety, dupilumab and tralokinumab have an optimal safety profile. We all know that, and we all use these drugs in eczema patients, and the data so far prove that these drugs can be safely prescribed. Um, in fact, dupilumab's mode of action make it an optimal choice in refractory pruritic immune-related cutaneous adverse events, with many recent published data in the literature. We practically use it in every severe or refractory to topical treatments pruritic skin toxicity, such as eczematous rashes, bullous pemphigoid, and severe pruritus per se. We also use it in pruritus accompanying, like severe pruritus accompanying lichenoid rashes or psoriasiform rashes. But I believe that for psoriasis, also other biologic targeted treatments are first line and work better. And I also believe that it is a good option for those patients in whom systemic steroids are contraindicated, because we know that there are many fragile patients, and we know that not all of them can get systemic steroids, and they suffer also from other comorbidities, and they take a lot of other medications. And I think in this scenario, we can also use with safety dupilumab in eczematous or pruritic rashes.
Good. I guess like it's actually a very good comment because if when the oncologists are listening to this podcast, it will be like, whoa, we're just usually using systemic steroids in these patients, but now we can actually use other therapies that maybe they're not that aware of. So that's why dermatologists should be more involved in the management of these patients. All right. I would, we're talking about fascinating things, biologic and novel therapies, but I have to talk about the elephant in the room, which is money and prices. So we will have, we might be facing difficulties in our hospitals to get reimbursement or approval of the therapies. And I will talk about Spain, for example. There are differences and disparities between hospitals, even in the same city, because the decisions are made about the approval of these drugs by the pharmacy of each hospital. So it can be easy in some hospitals, in others not so easy. But I would like to hear from you guys. How is in France, for example, Dr. Sibaud, the approval of these therapies for cancer patients? Do you have any difficulties just because they have a background of cancer or an active cancer?
Yeah, sure. The main issue primarily concern reimbursement and registration. In fact, in clinical practice, this is not a big issue in the context of the use of biologics, including IL-23 inhibitors in the treatment of psoriasis induced by immune checkpoint inhibitors. However, when it comes to treating a pruritus, persistent eczema-like reaction, the limitation and the borders are less clear for anti-IL-4 or EGA monoclonal antibodies. So it is true that the recent publication and the development of evidence-based medicine has helped with prescribing, as well as the indication, including in the US in the NCCN recommendation. So we know that, for instance, as previously said by Zoe, anti-IL-4 represent a very effective steroid-sparing agents, which can significantly limit the negative effect of immunosuppressants on tumor response. So it's a conflicting situation. So my recommendation in all cases, I would recommend I would recommend that the decision to introduce biologics in cancer patients for the management of immune checkpoint inhibitors induced skin tox should be made and validated collectively in a multidisciplinary meeting involving for sure medical oncologists, but also dermatologists, and if it's possible, in a specific center with oncological expertise.
Thank you so much, Dr. Sibaud. I think that we have discussed this also many times, and I have heard from Apala. What do you think about this when you're facing, you try to convince the pharmacy from the hospital about getting one of these drugs? I know I heard you once saying, it's actually the thing that we generally use also in Spain, like it's a psoriasis. No matter if it has cancer or not, it's a psoriasis. So the patient requires this specific therapy. So what do you think, or how do you handle these situations if you have difficulties
Uh,
in
as you said, when we are in the licensed indication, things are easier, and we just need to apply for our patients individually for each one of them to a specific board which is responsible to give access to these drugs, and it is easier when when we ask the treatment for the licensed indication. When we ask the treatment for a scenario which is out of the licensed indication, off label, as we usually say, then we need to use more arguments to explain that no other option has worked so far. And I think that at least at the moment, it seems that the authorized boards are quite sensitized towards cancer patients, and they try to facilitate the process to the greatest possible extent. This is my experience in Greece, and as you said, it is always hard to get access to these costly, very costly treatments, but I think that for cancer patients, it's worth to do so.
Yeah, and I think it's also good to highlight that there is more and more evidence and recommendations from even the European and American level as well for using these therapies and getting a.
Exactly, exactly. We use these publications as an argument when we do the application for our patients. This is very important to have data.
We can also add that in most cases, the treatment is a short-term therapy because the patient will be treated only a few weeks or few months for this skin tox. So it is limited in terms of cost and time.
Very good points. I think that we're gonna just start to wrap up this. We have been told we can talk for hours here, but we have a limited time. And I just want to have in one, just few words, Dr. Sibaud and Dr. Apala. What are your perspective of the unmet needs regarding the management of side effects of immune checkpoint inhibitors?
Well, from my side, what is really lacking in order to optimize the management of toxicities in general associated with immunotherapy are the development of predictive factors for their occurrence, not only for the skin, once again, but also for rheumatological toxicity, neurological toxicity, cardiac toxicity. So there is a particular lack of companion biomarker, especially serum biomarker, that could identify patients at higher risk, which will enable specific dermatological monitoring from the outset, from the beginning, and personalized care based on elevated biomarkers. So this is my main comment. In terms of clinical symptoms, I would say that in my experience, probably the most difficult symptom and toxicity to manage is the development of induced xerostomia, which is so difficult to manage with a very huge impact in terms of quality of life of patients. And I don't have any magic bullet for the management of such patients.
So
Well, of course, I totally agree with the comments of Vincent, but I would like to add also the optimization of the collaboration between the different specializations. I think that we must stay alert. We must increase awareness also of oncologists and also oncologic nurses that they deal with these patients in order to make their life easier and provide them the best options and improve their quality of life. This is one thing that I think we have still something to work on.
yeah, yeah.
To conclude, I will say keep pushing.
Keep pushing for this. Yeah. Well, I would like just to close now the podcast. I would say that all these side effects that we have been talking, they're manageable. That we have options as dermatologists. We could do a lot for our cancer patients to improve their quality of life because the main endpoint of this is getting to this, letting them to finish their treatment and succeed on the treatment and help them during the process of their cancer treatment with our tools that we have. We need to also get more involved as dermatologists, make a proper diagnosis, go with this treatment with phenotype driven treatment, including, for example, specific therapies, and get, as we mentioned before, the multidisciplinary approach to cancer patients is essential for this. Vincent, so thank you so much for sharing your expertise, your practical and personal approach and insights on this point. And thank you to our listeners for joining us today.
Thank you so much.
Thank you. Bye.